Hi, everybody. Thank you for joining. Looks like there's some people still joining, so maybe I'll just give it another minute before we get started here today. I see the numbers kind of climbing quickly, so just give everybody a minute. Thank you. All righty. Got some good number of participants so far, so let's go ahead and get started. We don't have a ton of time today. So hello again, everyone. Thank you so much for joining the second of our two-part webinar series this month, Moving from Data to Action for Health Equity. I'm Emily Hummel. I'm a Senior Account Manager here at HCI, and I'll be the moderator again for today. So I know we do have a limited amount of time together as usual, and we have a bunch of good information to share. So just a couple quick housekeeping things. You all are obviously joined as an attendee, so you're muted automatically for the duration of the webinar. But if you have any questions at any point during the presentation or the slides, there is a chat box in the bottom right-hand corner of your WebEx screen. Please feel free to type any questions into that chat box, and it will come to everyone. And we'll get those answered as we're going through, or we'll bring them up at the end when we have time during our Q&A session. And we're monitoring those as they come in, so we'll try to answer as many as we can. And then lastly, a recording of today's webinar will be available to everyone. So with that, let me quickly introduce our speakers for today. These faces should look familiar to you if you joined part one of our series earlier this month. So first off, we have Ashley Went. She is a public health consultant with HCI. Ashley brings over 15 years of public health expertise and experience to the Conduent HCI team. This experience includes domestic and international public health work, and Ashley earned her Master of Public Health degree from Tulane University. And then also with us today is Jane Chai. She's our community health content expert. Jane has been in community health for the past 20 years, and prior to joining HCI, Jane actually worked at the local health department in Orange County, California for 15 years. And she was responsible for coordinating community health planning, strategic planning, workforce development, and quality improvement during her time there. We're really lucky to have Ashley and Jane with us again for this part two. For those of you who aren't as familiar with who we are, Healthy Communities Institute, or HCI as we refer to ourselves, has been a leader in community health for the past 14 years. We've conducted over 250 community health assessments and implementation strategies with our partners that we work with across the country. We also provide strategic direction for community health initiatives, and we're known for our award-winning customized technology platforms. Along with powerful analytical tools, the platforms provide access to continuously updated population health and socioeconomic data to help tell a community story and improve the health and the work that you're doing there. HCI employees bring both a combination of advanced public health experience and degrees, as well as real-life experience in community benefit and population health. So now that we've introduced ourselves a little bit, we're going to be turning off our cameras just so the audio is maximized for the duration of today's webinar. And with that, I just want to quickly introduce the objectives for the webinar series. So today is the second of the two-part health equity webinar series, Building an Equity Lens into Your Next Community Health Assessment and Plan. During part one of the series back on June 9th, we discussed setting up your assessments with a foundation for equity, with partner engagement, foundational agreements, and a framework for reviewing data. If you missed that webinar, you can view the recording, which I am now sending in the chat. You can find the link in the chat box on the WebEx screen, and you'll be able to view that part one of the webinar series. For part two today, we're going to be discussing how to effectively tell your community's story and track your plans around equity. with that, I'm going to pass it off to Ashley to take a deeper dive into the detailed objectives for today.
Thanks, Emily. So I want to take just a bit of time to talk about our objectives for today. So we will be covering ways to tell your community story with meaningful data that help identify local priorities and health disparities. We'll create short and long-term performance measures to track improvement on health and health disparities, and utilize findings to engage community partners in multi-sector collaboration and shared action around equity. So for those of you who were able to join us for part 1 of this webinar series, the next few slides will be familiar to you as we center our conversation for today. The graphic here shows the community health assessment and planning cycle. We discussed this a bit in webinar 1, where we focused on the first part to this process, including setting up foundational agreements and frameworks and engaging partners in our work. So today we're going to continue the discussion with the latter parts of the assessment cycle, including synthesizing data, activating findings, and implementing and tracking our plans. In webinar 1, we also discussed the specific requirements for each entity, whether you're working in a hospital community benefit team, a health department, federally qualified health center. But since we covered this in part 1 of the webinar, we won't go over them in depth today. But if you missed it, please feel free to revisit the webinar recording for that information that Emily's already shared. Now we're going to go on to explore how we can analyze community data from our assessments with findings and equity in mind. So as we shared in part 1, these are the types of questions we are looking to answer when we are conducting a community health assessment. And since this webinar series is focused on health equity, we wanted to dive in a bit deeper into how to look at data to explore disparities. We go through this extensive process to obtain secondary data like this, in addition to community feedback for our assessments. But once we have this data, how do we go on to show it in a compelling way? When we're thinking about data, it's important for us to consider a few things. We have to think about having a diverse set of secondary data indicators. We have to be intentional with the development of our community input tools, whether we're developing community survey questions, facilitation guides for key informant interviews or focus group conversations, because this qualitative data is really an opportunity to add real-time community feedback to our process and lift up community voices that may not be represented in secondary data. It's also important to think about having a diverse set of community participants. And it's always good for us to think about and identify who is not yet at the table. So here on this slide, I want to revisit the modified bar-high health equity framework that we discussed in webinar 1, as we think about the types of questions and data that would be meaningful for us to collect from the community to better understand these upstream and downstream factors that impact health. Better understanding social inequities related to living in poverty, for example, or more clearly understanding institutional inequities and the barriers they can create, such as whether you have access to a healthcare provider or not. We can also look at those related to our living conditions. Overcrowding housing, for example, was of particular concern during COVID because it increased people's potential for exposure to the virus. So it's important for us to not only think about and understand the health outcomes that impact our communities, but also all the surrounding factors that influence an individual's and community's health as well. To take that thought a step further, I want us to think beyond just identifying what health issues are impacting our community then. Typically, the results we are aiming for from our community health needs assessments is identifying what are the key health themes emerging from secondary data and community feedback so we can prioritize them and move on to build our strategy and work plans. There are other opportunities, though, to push ourselves beyond just identifying these health areas. For one, we can think about the who. We have the opportunity to understand which populations within our communities are experiencing disparate health outcomes due to barriers and challenges. We can identify disparities within data sets by analyzing our data by available demographics, such as age, race, ethnicity, sex. This is more important for meaningful secondary data analysis, but it can also be applied as we analyze our community feedback as well in our community survey results, as well as looking at our qualitative data. Additionally, we can also begin to think about the where. So we have the opportunity to understand which portions of our communities are experiencing disparate health outcomes based on where they live. We all know, or we've heard, that where we live can have a much greater impact on the health potential than anything within the health system. So we should better understand these geographic variations to better define and target our work to make the biggest impact. And these geographic analyses can include mapping, visual indices such as Healthy Communities Institute's Socio Needs Index Suite that we'll take a look at a little bit later, heat mapping of available resources. This is really our opportunity to zoom in on a city center, a zip code, or even census tract as the data allows. And finally, going back to identifying the what, we can also better understand how the identified top health needs from our assessments vary by population. Overall, a certain set of health needs may trend to the top, but as we look at health needs by specific populations, such as the 65 and over population, for example, the top health needs that they experience may vary slightly. So we can begin to consider these variations as well. So in the next few slides, we're going to look at a few more client examples of how we combine different data and data analysis to create a clearer, more targeted picture using our data. So in this slide, for this client example, we explored how rising housing costs are affecting vulnerable populations in this community. 60% of the community survey respondents for this community survey said that there were not affordable places to live in their community. And then the secondary data supported this point, showing an increase in the median household rent over time. And then finally, we layered in additional data that highlighted poverty differences by race and ethnicity for those aged 65 and older. In the next client example, we explored mental health, which was identified by community survey respondents as being one of the most important health issues that needed to be addressed in this community. Secondary data from Medicaid and Medicare services illustrate an increase in depression among the Medicare population over time, and additional context was layered in from community survey respondents who reported unmet mental health needs in the past 12 months by race and ethnicity. Of course, another way to look at data is by looking at geography, as we discussed. Using indices such as HCI's Socio Needs Index Suite gives us the ability to map data by city, zip code, census tract, or other regional groupings to help illustrate which communities may be more at risk. In this example, we're looking at an output from our Health Equity Index. As mentioned before, where you live can be a large indicator of your health, and HCI's Health Equity Index is a measure of social and economic determinants that are correlated with preventable hospitalizations and preventable death. In high Health Equity Index zip codes indicated in darker areas of blue, residents are expected to experience greater burdens related to preventable health issues. Again, looking at the opportunity to better understand where can help us focus our work where there are the opportunities to make the biggest impact. And finally, I want to emphasize that another important part of meaningful analysis is looking at an issue from multiple perspectives or data points. For instance, you're seeing 3 maps of a county here from left to right. The maps are showing by zip code adults who are sedentary, adults who are obese, and adults taking medications for high blood pressure compared to state zip codes. From these maps, you can really begin to see that the same communities are at higher risk for being more sedentary, are more likely to have higher rates of obesity, and use medications for high blood pressure. And we're not drawing any causal conclusions here, but looking at the data in this way can help us confirm, 1, that the data makes sense, and 2, that there is the ability to identify potential action points. So depending on where your community is in terms of health equity work, you might go even further upstream and look at issues such as education, income, or housing conditions, and how conditions in these areas can help you identify areas for cross-sector collaborations. And we'll talk a bit more about this a little later. But now I want to pass it off to Jane, my colleague, to discuss a little bit more in detail about how we can begin to track and measure our success implementing our strategy and work plans.
Thank you so much, Ashley. Ashley just did a great job discussing how to analyze data with an equity lens. And let's now just shift gears a little bit and talk about how to create an evaluation framework with this data in mind. So we'll start by talking about short and long-term outcomes, which are measured by performance measures. Performance measures help show how we're progressing on our shared objectives. There are generally two types of performance measures that communities use when tracking progress and impact. Community level indicators measure longer term outcomes for a whole community. So for instance, prevalence of obesity for a zip code or a county. And program specific indicators will measure shorter term outputs or outcomes. For instance, the number of people who completed a diabetes management class. So there's often anxiety or confusion about which ones to track. And we find that you really need to track both. Community level outcomes gives us an overall picture of what's happening in our community and whether we're getting closer to our goals and vision. And program specific indicators give us more real-time input about actions we're taking to impact shorter term objectives. So as part of your process, you probably identified a shared vision that guides your efforts with your partners. To help us better see what outcomes to track, we recommend using a logic model or an evaluation plan that helps you better understand how to move from that shared vision to shared action. And based on that shared vision, most communities decide on 3 to 5 priority areas for shared goals. Goals tend to be loftier, longer term, and look at community level impact. For each goal, communities typically have another 3 to 5 objectives with set targets for a shorter time frame. Many communities will also name a range of strategies to help guide the activities included in the plan. For instance, a community might indicate that they'd like to have strategies that work at the individual, organizational, community, and policy level. And finally, for each objective, you likely have another 3 to 5 activities that support those objectives, which are tracked more regularly, like monthly or quarterly. So here's an example of an evaluation framework for one priority area with the elements we just discussed: a high-level aspirational goal, measurable objectives indicating a baseline and targets, types of strategies to include, activities to be tracked, and a reporting structure indicating responsible parties and how the data will be collected. And you'll notice that the types of strategies range from those at the individual to policy level. Including strategies at the organizational or policy level is especially important when equity is a key consideration for your plan. Next, we hear from our clients' concerns or questions about how to incorporate health equity into their performance measures. I think a key concern is wanting to acknowledge that this is an important part of our work, but also wanting to be realistic about what can be done in a 3 to 5 year plan. We've seen this done a few different ways. Some communities use health equity as a lens that informs how they look at indicators and targets for their plan. Some might use a framework, as we discussed in part 1 of our series. For others, it might be part of their vision statement or foundational values, and some will have it as a goal or priority area. If you're looking to use performance measures to track progress on health equity outside of health indicators, a good place to start is by assessing your current state. The American Hospital Association's Health Equity Transformation Assessment and the Bay Area Regional Health Inequities Initiative, or BARHI's organizational self-assessment tool, can help identify areas for action at the organizational, community, or policy level. So examples of performance measures that might come from those assessments might include the number of non-health agencies, such as those in the housing or transportation sectors, that are participating in your partnership, the number of partners or programs that are collecting data with race ethnicity breakouts, or the number of programs that are conducting a social needs screening. As we mentioned, these are more system level changes that can have impacts on social determinants of health and health equity in the long run. So let's now talk a bit about setting SMART objectives. We're guessing that most of you have heard of SMART objectives or objectives that are specific, measurable, achievable, relevant, and time-bound. And at the top of the slide, we're showing an example of the typical layout of a SMART objective. We, of course, always recommend using SMART objectives, the SMART objective approach, when setting up your performance measures. And there are a couple of new parts of this acronym that we think are really important, and those are inclusion and equity, making this a SMARTIE objective. The addition of inclusion pushes us to engage historically excluded groups in our process, while equity pushes us to consider how the objective moves us forward towards equity. So let's get into some examples of how you might incorporate some of these elements we just discussed. Here's an example related to obesity, which is a common priority for our clients, so obesity or other chronic diseases. The goal stated is taken from Healthy People 2030. It's at the community level and feels very lofty, and there's no time frame or target stated here. Our objectives, though, has a time frame and calls out cities that we want to focus on in order to address some of the disparities we found in our assessment. Here we note that if there are stated objectives to address a disparity like we're showing, it's very important to work with community members and partners to make sure that the objective is framed in a way that's appropriate and respectful. Also, consider how you'll ensure that strategies are inclusive of communities who are impacted. So for instance, in this example, the activities to support our objectives include empowering resident leaders and working with them to increase school wellness policies in higher risk cities. So those strategies are utilizing a health equity lens by incorporating system and policy level strategies that include communities impacted as part of the solution. Here's another example of a priority for many of our clients, behavioral health. Ashley talked a little bit about this earlier. Note here that the highest level is labeled priority area rather than goal, and the lowest level is labeled strategies versus activities. We wanted to acknowledge that different communities sometimes use different terminology. At HCI, we're not overly prescriptive about terminology. We just recommend that you use what works and makes the most sense for your community. So moving on, another factor shown here is considering the current trends when setting targets. Ashley actually showed a chart earlier where trends of depression among the Medicare population was rising steeply. So in such a case, you might use an objective like the one we're showing here to stabilize a rate rather than reduce it. And if you find that you're doing better than expected in a year, you can and should always adjust your target to reflect those changes. And from an equity perspective, you can also choose to focus on a particular population if that makes sense based on your findings. And finally, this example shows a tiered approach with activities happening each year, as well as a range of strategies for individual and system level improvements. We know that this is a lot of information, but we wanted to just share some of the ways that you can work these types of considerations into your plan. So now I'm going to turn this back over to Ashley to talk about engaging partners in your collaboration process.
Thanks, Jane. So now we're going to revisit the idea of meaningful collaboration that we really began talking about in our first webinar in this series to discuss how our collaborations can make meaningful impact in our work. I encourage everyone that I work with to really see their assessment process as an opportunity to strengthen their existing partnerships and grow and develop new ones, identifying who is not already at the table, but also looking at who is already doing meaningful work in the community in the areas you know that are important to the work being done, and inviting them to be a part of your process as stakeholders, key informants, participants in your prioritizations. And as you begin to develop and implement your strategy and work plan. So we really should be working to build these partnerships and conversations in all throughout our assessment and plan development process. And building on the items Jane just discussed about building evaluation frameworks for our work plans, we can also be intentional in our work in collaborative partnerships. The power of collective impact is that we can work together intentionally and share information so we can work to address more complex problems. And we can accomplish this by identifying shared priorities and common goals, ensuring that we're tracking common data for measurement and evaluation, that we're amplifying mutually reinforcing activities using a common platform or evaluation tool, and that these types of joint platforms or tools can serve as a hub for ongoing infrastructure and communication. An example of one of these tools that can support collaborative work is a comprehensive community health dashboard like the one shown here. Tools and resources such as this dashboard can help bring data points together and help answer data questions that can guide our ongoing work. This is an example of a dashboard that shows values for various indicators in one county compared to state and national values, as well as general trends in Healthy People 2030. Having a range of indicators on a dashboard will help you tell a more complete story, indicating where the community is doing relatively well and where it's falling behind or where trends may be worsening. Many of our clients will have a range of, say, 150 to 300 indicators on a community dashboard, but after their assessment and evaluation development as part of their strategy and work planning, they may have a smaller subset of indicators that they plan and identify to track over time for their community assessment or specific priorities. And we've already seen a few examples of these indices today, but I wanted to revisit them here collectively because many of our clients and their partners are looking at topics such as food insecurity as an opportunity to bring multiple sectors together for collective work. Food as medicine is a growing trend in areas of focus and work among health systems and their community partners, like regional food banks. And highlighted here, Conduit's Socio Needs Index Suite provides visual analytics around social determinants of health that can be leveraged through analysis and planning to advance equitable outcomes. In this slide, we are showing a side-by-side mapping of age-adjusted hospitalization rate due to diabetes alongside results from HCI's Food Insecurity Index that illustrates where residents are experiencing higher levels of food insecurity and greater social and economic hardship. We see much of the central area shaded in red overlapping with the darker greens in the Food Insecurity Index. So there is an opportunity here to explore how access to healthy foods could potentially influence the higher rates of diabetes-related hospitalizations that we are seeing in these zip codes. And finally, in this last example of collaborating and identifying common data for measurement, tracking, and planning can create opportunities to identify areas for investment and action. Here we see clinical data highlighting heart failure readmission rates by geography, where areas in red indicate higher readmission rates. Looking at this clinical data side by side with an output from our Health Equity Index, we see that a stark difference between the Health Equity Index results for zip codes 75019 and 75216, where 75019 appears in a much lighter blue in the Health Equity Index than 75019, which appears in the darkest blue. And this indicates that this is a zip code where residents are expected to experience greater burdens related to preventable illnesses. So if I was looking at this with my team or my collaborative partners, I would encourage us to dig a bit deeper into what's really going on in the environment in these communities, because they're having similar clinical outcomes, but their socioeconomic indices scores show that something different is going on in the environment. So now I'm going to pass it back to Jane to show us some client examples that allow us to pull everything that we've talked about together today in a more meaningful way. So Jane?
Thank you so much, Ashley. Yeah, we're now going to look at how we might pull all of this together by sharing some examples from our clients. So the first example is from Think Health St. Louis, led by the St. Louis Partnership for a Healthy Community in Missouri. And this is their landing page for their community health improvement plan. During part one of our webinar, we talked about setting up foundational agreements around equity. And this is a great example of a group that's done this and are showing that addressing the root causes of community health and promoting health and racial equity are some of the pillars of their work. This sets up the foundation for their priorities, which include improving access to community health, chronic disease prevention and management, violence prevention, maternal, child and family health, and sexual health. So now let's dive into one of these priorities. We're showing their page for their maternal, child, and family health priority. And you can see that they've identified a fairly broad goal to reduce Black infant mortality by 20% by 2024, and then identified more specific objectives and strategies around ensuring community-led decision-making, addressing social determinants of health, such as transportation and housing, addressing safe sleep, and improving perinatal care. Each of these gets into more specifics of how infant mortality might be addressed. And as we scroll down, they're also showing some of the community level indicators related to maternal, child, and family health, such as babies with low birth weight, infant mortality, prenatal care, and preterm births. I think this is a great example of how you might incorporate policy and system level strategies to advance equity for a health priority. Now we're going to shift gears a little bit. We're going to look at an example from Data Share Santa Cruz County, which is a site in Santa Cruz, California. This page focuses on some calls to action for addressing inequities based on sexual orientation and gender identity. Again, they do a nice job setting up foundational concepts and shared definitions, and linking to data points that tell the story behind the data. And then to some best practices for collecting information about gender identity and sexual orientation. As we discussed earlier, many of our measures around equity may push for organizational changes. And in this case, the push is for collection and analysis of data for sexual orientation and gender identity, which we really appreciate because we know that data can help us describe the disparities and advocate for programs or policies. And as a note, collection and use of data to drive action is also one of the 6 levers of transformation as part of the American Hospital Association's Health Equity Roadmap. And finally, the page goes on to show the existing data that have subgroup analysis by gender identity or sexual orientation. So thank you so much for taking this tour with me, and we're going to move on to our last example. So the last example we wanted to show is a page from Prince George's County in Maryland, which shows some system level objectives for improving health equity. Again, there's an introduction to the work group's vision around equity, and the page really acts as a hub for the work group's activities by sharing reports, plans, and toolkits, which we see as we scroll down. And like the other pages, it's used to highlight some of the community level indicators they're looking at for their health equity work, including high school graduation, adults with health insurance, and people living below federal poverty level. And as we scroll down, we see that they have 2 major goals in their work plan that focus on policy and systems change. The first is to promote and advocate for health equity, which includes some shorter term objectives, as we talked about, to advance policy recommendations around health equity. And we can see they've made some progress on this. Their second goal is to engage the healthcare system to advance health equity. And we see that some of the objectives and strategies for these include actions around health literacy and developing a communications framework. And that takes us to the bottom of the activities for this work group with some information about their upcoming meetings. We love that this and the other 2 pages really illustrate the collective impact approach that Ashley talked about earlier, with shared priorities, common data for measurements, and a hub for communication. So now that we've taken a look at these examples, we're jumping back into the PowerPoint. We hope that you found those examples helpful and they've inspired you to think about how you might tell your community stories around data and move from data to action. So that concludes our presentation portion of the webinar and will lead us into the discussion portion of the webinar. So please feel free, as I think Emily directed, to ask us any questions in chat. You can direct them to all panelists as well. And I think at this point, we're going to turn our cameras back on so that you can all see us. Emily, can you share if any questions have come in so far?
absolutely, yes. And it looks like we have some time. So let me pull up one great question that I think is a common one that we get sometimes. And it is, our county population is very small and we find that data is not very reliable. Do you have any recommendations for this?
Yeah, I'll go ahead and take that one. I think I agree, Emily. This is something I think that comes up a lot as we're working with different communities. And we know that there are some reliable data sources out there. American Community Survey publishes 5-year estimates for areas with small population size. CDC also has CDC Places, as well as their small area health insurance estimate. So those are a couple of data sources that are really meant for those with small population sizes, and I'm guessing they mean something like under 10,000 population. And we certainly have lots of clients with that demographic or that population size, and they have that data on their platform as well as in their CHNAs. But we've heard that as a challenge. I think the other thing you can do is look at aggregating the data. So sometimes if you're looking at single year data for small population sizes, it can get kind of unstable. But if you aggregate the data, say by 3 or 5 years, then the trends kind of smooth out a little bit and it makes it more comparable or more easier to compare to other areas. And then the last thing that I think Ashley can maybe speak more to this, that we always recommend, because sometimes there's a lag in the data, or with quantitative data, there are often gaps in there that we want to fill in with understanding the lived experiences of community members. It's to supplement that data with additional data collection, either maybe through focus groups or additional surveying or key informant interviews. So I'll actually turn this over to Ashley in case she has anything to add on that topic.
No, Jane, I think you really hit it on the head there. I think what I would just reiterate is that, there's power in getting that additional community feedback. As you mentioned, especially during COVID, we're seeing a lot of these national data sets being a little bit delayed in when they're coming out. So we're looking at data coming out a few years behind. So to really engage with what the community is experiencing real time, relying on community surveys that you can meaningfully put together with questions to really target community responses in these areas and focus on equity, and then building in that qualitative data either through key informants or focus groups is another area that you can really highlight community voices. And I mentioned before, you can really be intentional about who you invite to the table to participate, particularly in your focus groups, and really highlight voices that may not already be incorporated into some of those more traditional secondary data sets that we use.
Thank you, guys. Let me see. We have actually a question that just came in. I'm just clicking so I can read it. We are planning to obtain information through our community health survey. Any other suggestion of different ways to get information from minorities that are not traditionally represented in the standard health indicators?
Yeah, I would say, I have a colleague that says, plan as you want to end. So I think being very intentional with how you plan your process, both, again, who you have at the table in discussions as you begin to work on your assessment, as you begin to pull your tool together, if you're working on that community survey, looking at building in intentional questions, not just asking the basic, health outcomes that we've typically built into these surveys, but asking questions about food insecurity and housing insecurity. And, I see clients now wanting to ask more specific questions around equity and experiences of discrimination. And some are even, feeling comfortable enough to ask more specific questions around experiences of racism and how institutional racism may impact community health. So I think there's a way to bolster the community survey and how you build the tool, but also in how you are implementing it. So a lot of our surveys now that we work with our clients on are digitally distributed, but we also work to identify communities that may not have as reliable access to smartphones or internet services. So we still may complement that work with paper copies of surveys. I know we had a client recently that wants to reach out to the homeless population using paper surveys, or if they have certain refugee groups that we're ensuring that we translate those surveys into some of those more common languages other than English that are existing in your community. One good tip that I typically say is, look to your health provider and ask them, that's on your collaborative, and asking them what is their most common languages that they're translating for or providing services for in their clinical setting, and that's usually a good indication whether you need to offer your survey in English and Spanish, as well as another language like Burmese is another one. And then again, like we've said, that qualitative feedback as well, really using those focus groups to dive into specific community experiences. Again, those voices that haven't been historically integrated into secondary data. We typically include conversations with LGBTQ+ communities, youth, the 65 and older, Black African American populations, Hispanic Latino communities. So any diversity that is represented in your community that may not be as prevalent in your traditional data sets, I would encourage you to supplement that with these community feedback options in your assessments. And invite them back if they're participating as focus group participants, if they're participating as your key informants, bring them back to the prioritization table, help them verify and provide that agreement as you're talking around your prioritization, and invite those stakeholders back as you move forward and begin to plan your work plans as well. And again, it's that opportunity to build true, meaningful partnerships and collaboration in the work that'll get you so much further in addressing that equity. Emily?
Yeah. Oh, sorry. Can I add on to that? Yeah, and as what you said just reminded me of some things that we brought up in our first webinar. About asking them back, because we do, if you're going to do this, we do have some tips about engaging community partners, especially, and community members, especially those who maybe aren't used to the process or that data. So please, I know Emily linked to the webinar earlier, but please go back to that. And then I don't remember if you mentioned this, sorry, already, but we talked also a little bit about, we know that traditionally, historically underrepresented groups or groups that have been underserved have also been, oversurveyed or overstudied in some ways. So, before you start new data collection, definitely make sure to ask your local, if you have a center that serves, LGBTQ communities or an academic institution, like ask around to see if existing studies have been done. I know we've walked into situations where people didn't know that, like, just as recently as the year before, a major survey had been done with those communities, and that information can and should be brought in to your assessment, so we're not asking the same things of the same people who are already dealing with a lot of things, as we all are. So that's just another note there.
Yeah, Gina, I think that goes back to the environmental scan that we touched on, and kind of being intentional as we plan these assessments, not only to look at what we learned and prioritize and have made progress on previously, but also what else is going on in the community, what other assessments or studies are being done, what are other community partners doing, and how can we kind of coalesce our work around these efforts so that we're working together more intentionally and not over asking of the community at the same time.
Thank you both. That's great information. We have, I think, less than 60 seconds left. So, but we do have a few questions that came in. I just want to let those of you know that if you did submit a question, we'll follow up via email to you. So, hold tight. We'll definitely get you some information if we can help answer that question for you. And with that, I think I will go ahead and say thank you once again for everyone joining today. I hope it was helpful, and we really look forward to seeing you all at our next webinar, and have a great rest of your day.
Thanks for coming, everyone.